the speaker and the slide. Not everybody can do it, but if you can, it's useful.
Right. Does everybody know what she's talking about? If you hover up above and get it down to one little line, and then you see the full slide. So welcome everyone. So good to see everyone who has joined us. I know lives are getting busy now that we're all got our shots and we're like seniors on spring break, senior citizen spring break. Everybody wants to get out and do stuff. Like that's what Suzanne called it. So I do appreciate your time. And I am so genuinely pleased to be able to introduce these two physician friends of mine. Basically, I think Elizabeth has already covered this slide about the questions, but I just want to reiterate, we are recording, and that if you have a question that you haven't already submitted, go ahead and type it into the chat box. That will be visible to us, and then we can get to that. Thank you. Our two speakers tonight are phenomenal physicians and phenomenal human beings. I've known them only, I guess, a year-ish, a little less, but they, when we started Doctors Fighting COVID, they just jumped at the chance. They've been just incredible supporters of all things right when it comes to patient care. I can honestly say that. Dr. Suryaprasad, who I will refer to as Dr. Anil, after I got it out once, and then Dr. Reza, whoops, I'm sorry. Oh, I thought the bio slide was up there, but basically, Dr. Anil is an epidemiologist, trained in internal medicine, was at the CDC for many years. He now works through the CAN community clinics, where Dr. Reza also works. So he has a wealth of information, not only on internal medicine and infectious diseases and all that kind of thing, but also on pandemics, epidemics, and the CDC itself. So he's an excellent source of information there. And Dr. Mohammed Reza is an infectious disease specialist who works through the CAN clinic. They are located in Jacksonville and in St. Augustine, treating mostly, it's my understanding, mostly HIV positive patients, I believe. So without further ado, I'm going to let Dr. Anil take over here, and I will stop sharing because they're much better in live in person than the photos.
I'll go ahead and share my screen. There we go. So thank you all for inviting me to speak with Dr. Reza, and thank you, Nancy, for introducing me to so many opportunities to be able to engage with the community and work on advocacy. It's really broadened my spectrum of activities that I've been able to be involved in ways of impacting the community, which has been a great addition during an otherwise, terrible time for all of us with this pandemic. And borrowing on some of my past experience in public health and epidemiology, I thought I would start by focusing on the epidemiology and prevention of COVID-19. So first, looking at the daily trends and the number of reported COVID-19 cases in the United States, this slide here, borrowed directly from the CDC, shows on the vertical axis cases and on the horizontal axis time from the beginning of the pandemic to almost present day. And what you'll notice is that there were basically three peaks in this pandemic, and the most recent peak in the winter time, particularly December and January, showed a marked rise in numbers of cases, where at one point in time we exceeded 250,000 cases and reached over 300,000 cases on one day. And that fortunately has come down, but it has not gone away. And what we are seeing is a plateau phase now, where we plateaued at numbers of cases that are equivalent to what we were seeing in the summertime. And that means COVID is here. COVID, we will all benefit from all the preventive measures to be able to get rid of it. So a very valuable piece of surveillance data in public health is hospital data. New hospital admissions are characterized in public health surveillance for COVID-19. And all hospitals around the country share their hospitalizations for COVID-19 through their health departments to usually it used to go to the CDC, now it's going directly to a task force with another form of data collection. And what we've seen is that the trajectory of the epidemic has followed the same curve essentially as what you saw with cases, that hospitalizations truly did take off over that December, January timeframe, and they've come down, but they certainly have not gone away. And they are at levels that are either equivalent to or even slightly higher than what we were seeing earlier in the August, September, October timeframe. I thought this graph showing pneumonia, influenza, and COVID-19 death rates in the United States is very instructional to be able to bust one of the common myths that I think we all hear, that this is just like another flu. What you see on the horizontal, on the vertical axis are all the deaths due to pneumonia, influenza, and COVID-19 as a composite variable. And then broken down in the different colors, in yellow are the influenza deaths, in the blue are the COVID-19 deaths. And you can see that the magnitude of deaths that we've seen is much, much higher with COVID-19. On the right, these graphs can be sometimes confusing. On the right vertical axis are numbers of total deaths, and on the left are percentages. And the take-home point here is we've been above epidemic thresholds with COVID-19, and magnitudes higher than the numbers of deaths that we saw with influenza in any of the years in the past. This looks at the last 4 years. The last time we've seen deaths anything close to this was 1918 with the Spanish flu. So the daily trends in number of COVID-19 deaths are also characterized on the CDC website. You'll notice that a lot of the data that I'm presenting is directly from CDC, and that was partially on purpose because I wanted you all to know that data is readily accessible for your own view at one website, and there's many other sites out there as well. But here, when you look over time, the number of deaths initially had spiked on one particular day when we saw all the problems that were occurring in New York City and elsewhere. And but overall, the deaths were far greater in number in the December, January timeframe, reaching a peak of 5,500 deaths in a given day. And we are still at levels of 1,000 to 2,000 deaths per day, and it has not come down to a low enough baseline that we can be complacent. It's at a level where we are still seeing far too many Americans dying. And looking at this locally, these are some excerpts of CDC graphs of this, where you can pull up local community level data. So you can really get a sense down to your own communities that you live in. This is a 7-day average for Duval County from the beginning of the pandemic to March 6th, very recently. And at the top are cases, and at the bottom are deaths following from essentially the trajectory of the pandemic. And again, you're seeing the exact same trends in Duval County as what you were seeing nationally, that their cases and deaths rose in the December, January timeframe, which really has been the hardest hit area. And I think Dr. Reza, during his moonlighting time at Mayo Clinic, and a lot of our colleagues who work in the hospital can attest to the impact that this has had in the hospital setting. So the new talk has been about the variant strains of COVID-19 in the United States. And so what is a variant strain? Well, when we first think about viruses, we have to understand that viruses are always mutating as they replicate. By replicate, meaning they're increasing in numbers and they're reproducing themselves. And as this occurs and more transmission is occurring, that provides more opportunities for mutation to continue to happen. So as a result of this, variant strains have become widespread in the United States. And here I show you the United Kingdom, South Africa, and Brazilian variants as the most commonly identified and earliest identified variants. And as you can see, the United Kingdom variant is the most numbers that have been reported. And I emphasize the word reported because this is what has come to public health from sequencing of virus in testing in laboratories at CDC. There are other variant strains that have come out of California and I believe New York City as well. The one in California, for example, has been implicated as being associated with the rapid rise in cases that we saw in places like Los Angeles. These new strains are associated with far greater transmissibility. That's probably the most important and worrisome point here, is that the UK strain, for example, which is growing in number in the United States, is up to 50% more transmissible than the original strain that came out of China. And genomic surveillance, which is essentially, if you think of kind of like a fingerprinting of the genome of the virus, which is the genetic code of the virus. What we do in the United States is truly insufficient to be able to understand the extent of these variant strains in the United States. At one point in time, they were talking about, maybe 1% or so of strains being identified. I think that must have increased by now, but certainly not enough to be able to give you raw numbers. So when you see 3,037 cases, the actual number is far, far, far greater than that. And in fact, a lot of the epidemiologists and public health experts believe that the UK variant will become the predominant strain by the end of this month in the United States. So what that means is that we have a strain circulating and about to become the most common strain in the United States that is far, far more transmissible than what we had seen from January to December, January in the United States. So what does this all mean? Prevention is so important. And the two most important points, and you've heard this before, and it's repeated over and over and over again because it is so incredibly important. Please try to practice social distancing as much as possible, particularly when you're in public places, particularly when you're indoors. Trying to keep at least a 6 feet distance from other people. Some people advocate even longer than 6 feet, up to 10 feet. And this allows for less efficiency for a virus to transmit from one person to another. And wearing a mask. This graphic says a face cloth covering. We'll touch on face masks a little bit more in a future slide. But wearing a mask, both parties involved and distancing together can reduce that likelihood of getting COVID-19 substantially. And really, all forms of prevention are key. The other types of preventive activities you can partake in are trying to make sure you avoid close contact with other people that are sick. And if you yourself are sick, please stay home. Don't go to work. Don't go to the grocery store. Really just try to get some rest and relaxation. I think it's something that Americans are not always good at, but this is a time when it's important for our own interest and also for the public. Avoiding close contact with people who are sick, avoiding touching your eyes, nose, and mouth. I'm trying really hard right now to avoid doing that because I have a tendency to do that. But it is the way that respiratory viruses are transmitted, and practicing the social distancing that we talked about, and washing your hands. Frequently, I might find myself washing my hands 20 times in a day. And this with soap and water for at least 20 seconds or with an alcohol-based hand sanitizer, 60% alcohol or greater, and really rubbing that together for 15 to 20 seconds to really be able to get the full effect. So this brings us to the final point where I think we've all started to hear chatter about it or have actually started to get vaccinated ourselves. I've had the chance to get the Moderna vaccine, and Dr. Reza, I believe, got the Pfizer vaccine. Please, please, please get vaccinated when it comes to your turn, and please tell any and every family member, friend, colleague, the importance of vaccines. We're all, advocates for our own communities, and I think being able to help educate folks as to how to get vaccinated is also part of the solution. The first website at the top is floridahealthcovid19.gov /vaccine, the vaccine locator. This website will take you down to the county level where you can find places that are doing vaccines in your area. And the next website, myvaccine.fl.gov, will actually help you. You can pre-register to be able to receive vaccine in a given county. Typically, people choose the county they live in, but I think you can actually choose multiple counties, and you'll get notifications from those counties when the state-run vaccination sites have availability for you and can make an appointment for you. Other than that, know that all the hospital systems will have their own ways of registering as well, and the pharmacies have their own ways of registering. Publix, CVS, Walmart, Winn-Dixie are all doing vaccines. There are some other smaller shops that are doing vaccines as well. It's become much, much easier to get a vaccine in this day and age. It's still not easy. I can't, say that you snap your fingers and you're gonna have a vaccine at your fingertips, but it can happen the same week, much more practically now than I would say a month ago. And we now know that the groups have expanded. The 65 and older population still is a major priority to be vaccinated. And Dr. Reza will show you some data as to why that is a priority population. Now, persons under the age of 65 who are deemed medically vulnerable by a physician with a form that is signed by a physician can get a vaccine in a place where there's a pharmacist, nurse practitioner, or physician administering the vaccine. There is no rhyme or reason as to why they came up with that stipulation. Some of us believe that it may have more to do with trying to get business to particular places and maybe try to decompress clinics. But for whatever reason, you need to have that form and you need to go to a place with one of those types of practitioners available to administer. Healthcare personnel are a priority population, residents and staff of long-term care facilities, and persons 50 and older who work in areas of essential work, law enforcement, firefighters, and teachers. And in fact, teachers, I think, have expanded now essentially to all age groups. And CVS, I think, has provided guidance that they would do vaccines on any teacher of any age group, and I believe other places are as well. So recently, in this past week, some interim public health recommendations have come out to be able to tell fully vaccinated people like many of you what you can and cannot do. And while it is somewhat general and doesn't get to the level of specifics that a lot of people like, it's a starting point. And remember, recommendations like these get updated regularly. This is a living document, and it's something that every week is worth looking at to see how the perspective of public health experts has changed. And we know everybody's behavior is going to be different, but these is a good guidance to tell you what are considered to be safe and what is not. If you do get a vaccine, the CDC believes that it's safe to visit with other fully vaccinated people indoors without masks or social distancing, that you can visit with low risk unvaccinated people from a single household without masks or social distancing, and that you don't have to get a test or quarantine following an exposure if you're asymptomatic. Now, if you're symptomatic, you probably do. And what should they continue to do? They should continue to take preventive practices. Wear masks, practice physical distancing, wash hands, do these things in public, do these things when visiting others indoor who happen to be high-risk persons or household members of other high-risk persons, when visiting unvaccinated people from multiple households. Hopefully not too many gatherings because gatherings are not necessarily the best idea still. Avoiding medium and large size gatherings and getting tested if you're experiencing COVID-19 symptoms. So how can we optimize the use of face masks? CDC in the last month has actually come out with more specific guidance than was present in the first year. When wearing a mask, the fit of the mask and the filtration capacity of the mask are the two most important components. And the fit of the mask is what's sort of been lacking with a lot of the masks that have been used. And through some laboratory studies and exposure studies, they found that infectious aerosols were decreased by 95% when a underlying surgical procedure mask was covered with a cloth face mask. And what that basically creates in a combined fashion is a surgical mask that has better filtration and then a cloth mask that is more adherent to your face and reduces the leaking around the sides of your face. And if you think about that, 95% decrease is a substantial improvement in how this functions. And this is really the recommendation of how we should be masking in public with these variant strains that are now circulating. Some other effective options that they recommend are getting a mask fitter. These are actually plastic, basically molds that can be created with an app that creates a 3D mold of your face using the app. I wish I had the name of that. If I in the chat session, I'll search for it and let you know. I think there's multiple of these. And they'll be, I think you pay a small cost for it, and then they're able to mail one of these molds that's been fitted to the contour of your face, and that really creates a good seal. A less expensive and probably practical option is to get a nylon covering over your mask and be able to create more of a seal. The same theme is to seal around your masks with any of these different options that we're talking about, and that can improve the safety of what you're using. And face masks really do work. There's been so many iterations of political dialogue about face masks. And it's unfortunate that something that truly reduces cases and reduces deaths has become politicized. A CDC modeling estimate early in the pandemic had said that up to 59% of all transmissions occur from asymptomatic or pre-symptomatic persons. And these are people who you never know that they actually have the virus at the time that they're transmitting it to other people. Face masks really protect that person wearing the mask and also protect those around them from potential transmission of the virus. A mask is most effective when it's covering the nose and the mouth. We see that everywhere we go, that they tend to slip down. If you wear that cloth covering overlying it, that slippage does not happen nearly as often. County level data have actually recently showed a decrease in case death rates almost immediately after implementation of mask mandates in areas. This is some of the more powerful data that's come out in favor of face masks. It was released by CDC, I believe in the MMWR. And it really shows that when this is mandated across a society, we can see the prevention take effect almost immediately, within 1 to 21 days after its implementation. And that effect lasts up to 81 days afterwards when they measure this as well. So that kind of is a good segue for us to move on to Dr. Reza's presentation, which I'll pull up for all of you. Thank you all for being advocates and really helping out our society. I think we're all in this together and can overcome this pandemic we have so many great optimistic opportunities with vaccines, face masks, social distancing to be able to overcome what really has been a scourge for the last year plus in this country.
It's hard when you see face masks. I see less usage now than I saw, you know, a couple of months ago, which is discouraging. But anyway.
Yeah,
Great.
and we
Great,
we need more creative ways of being able to get the message out. That's the problem.
I think it's a good point that just because we have very effective vaccines, we're still not done with this virus. A lot of people say we're exhausted, we're tired of this virus. The reality is the virus is not tired of us. It just needs to find people, and we are kind of the wood for this fire that's burning throughout the world. So as much of the precautions we can take as a community, as a country, and as a world, the more lives we can save. So thank you, Dr. Suryaprasad, for that fantastic talk. And thank you for inviting us. My name is Dr. Reza. I'm an infectious disease specialist. I'm also the medical director for CAN Community Health, based out of Daytona and Jacksonville. We have 37 clinics across the country. I'm also a physician at Mayo Clinic. I did my training there prior to this. And I also work with my wife at Coastal Health Institute, providing alternative pain therapies, as well as acupuncture and different types of modalities. So next slide, please. So this table just catches me every time I talk about this. So this describes the rate ratio compared to 18 to 29-year-olds. And what it's looking at is hospitalization and death rate. And the one that I really want all of us to focus on, and when you go down to the age range of 65 to 74. So this is comparing every decade of life, 18 to 29-year-olds, and how people do compared to the 18 to 29-year-olds. So if you look at 65 to 74, you see their hospitalization rate is about 5 times higher. But when you move over to the death rate, it's just astonishing, 90 times higher. And as you move up a decade, 75 to 84-year-old, the hospitalization rate is about 8 times higher, but the death rate just jumps up exponentially, 220 times higher. And then as you get to the older population, 85 and older, I mean, that hospitalization jumps up to 13, and that death rate just shoots up to 630 times higher. So this virus is deadly for those over 65, as well as those having underlying medical conditions. So that's why it's so vital that we start off right from that older population, getting them vaccinated, because the age by itself increases your risk of dying from this virus. Next slide. So this is a 4-minute video that just gives a quick primer on what the messenger RNA vaccines are, how they were developed. It's a cartoon form, just sit back, and I think it's very informative in a cartoon document. There's no volume for some reason. Dr. Anil, you have to unmute, I think.
These vaccines work. Are they? Developing vaccines is usually a
Sorry.
Developing vaccines is usually a very lengthy process, taking on average 8 years to get approved. Since a few years, we have the ability to create mRNA vaccines, which can be developed much faster. So how do these vaccines work? Are they safe? And how do they compare to traditional ones? But first, you must understand how the immune system works. When a virus enters your body, it will attach itself to one of your cells and inject its DNA or RNA into it. This is like a blueprint for your cells, containing instructions on what the cell has to make. So in this case, the virus's RNA will tell your cell to make more copies of the same virus. They become factories, assembling new copies of the virus that can infect even more cells. But don't worry, our bodies have a defense system for foreign intruders. The immune system attacks any protein, virus, or bacteria that does not belong in our bodies. But it takes a few days for it to learn how to attack the intruder. Meanwhile, the virus factories are running nonstop, quickly replicating the virus and spreading it in your body. In other words, you start experiencing symptoms of whatever has infected you. After a few days, however, your immune system will have figured out how to attack the virus and will start producing antibodies. These attach themselves to the virus, preventing them from infecting more cells and marking them for destruction. As you can see, the immune system is remarkable, but it's slow to mount an attack. That is the reason why we can get sick in the first place. So to give it a helping hand, we developed vaccines. The main idea is to train your immune system to recognize and fight off an infection before it has occurred. Almost like showing your immune system a mugshot of the virus and saying, if you see this, kill it. There are various types of vaccines, but let's take a look at the new kid on the block, mRNA vaccines. To understand how they work, let's take the COVID-19 pandemic as an example. You might have seen pictures of the virus with its distinctive spikes. These spikes allow the virus to attach to specific cells in your body and infect them. Now, here's the key idea for the COVID-19 vaccine. What if we could train our immune system to recognize these spikes by having our own bodies produce them? To do that, researchers took the virus's blueprint, its RNA, and isolated the part responsible for producing the spikes. Armed with this blueprint, they created mRNA, or messenger RNA. This is a special form of RNA that can enter your cells and give them instructions. In this case, the RNA contains instructions to build the spikes of the coronavirus. Not the virus itself, just the spikes. So mRNA vaccines contain instructions for your cells that tell them to build a part of a virus in large volumes, almost like giving them a recipe to follow. Once this is happening, your immune system kicks into action and starts learning how to attack these intruders. Again, it takes some time for the immune system to fight off these spikes, but you won't get sick because it's only the spikes, not the virus itself. And that's it. Your immune system has learned how to attack the spikes of the coronavirus. It destroys all the spikes and even breaks down the mRNA vaccine itself. The only thing left in your body are special B cells or memory cells. These can linger around for months or years until the same virus infects you again. When that happens, the B cells can produce the correct antibodies right away, preventing the virus from spreading and making you sick. What's interesting about this mRNA technique is that it's relatively quick to develop a vaccine as soon as we know the DNA or RNA sequence of a virus. And secondly, because the vaccine only makes our bodies produce a tiny part of a virus, we cannot get sick from it. More traditional vaccines use weakened versions of the actual virus. This also triggers an immune response, but could also give you mild symptoms. Now you know how mRNA vaccines work.
Next slide, please.
Take my word for it. Developing vaccines is
Great. So this is a quick overview and a table of the different vaccines that 3 of which have been authorized in the United States. Those equal on top the Pfizer, Moderna, and the Johnson & Johnson. AstraZeneca is requesting an emergency use authorization as well coming up in April. The messenger RNA technology is what the Pfizer and the Moderna vaccines are using. The Johnson & Johnson vaccine is using a slightly different messenger. It's using something called an adenovirus, which is a harmless piece of a virus where we've put into the spike protein, and same way that's being injected into a patient and the body's making those spike proteins. So they work in similar mechanisms. The Pfizer and the Moderna vaccines are 2 shots over a period of time, whereas the Johnson & Johnson vaccine is a single shot thus far. There are studies ongoing right now to see if 2 shots provide further protection, but Johnson & Johnson has not released that data yet because those are ongoing studies. So those are the different vaccine types in the next line. And the next line below that, the disease prevention in clinical trials, this is important because it's hard to put these together and compare them as apples to apples. It's more of looking at apples to oranges because the messenger RNA vaccines were developed when we didn't really know many of these variants that existed. So whereas the Johnson & Johnson vaccine was tested across the world, so we saw pretty diverse variants that this vaccine came up against. And so the efficacy, the effectiveness of these vaccines may be a bit lower, but the reality is they're all very important in doing what the next line shows is, Dr. if we could press enter, the hospitalization and death rate. So all of these vaccines are effective in what we want a vaccine to do, and that is preventing death and preventing hospitalizations. And you can see the storage is also very different. The Pfizer and the Moderna vaccine can be stored at sub-zero temperature they have to be, whereas the Johnson & Johnson vaccine can be stored in a refrigerator for up to 3 months, which really changes how far these vaccines can reach in terms of across the world or across our country. So next slide, please. So common side effects of these vaccines, you do get the injection in your deltoid. And a lot of people have said, I didn't even feel that shot. It was, we were all stressed out about it, but I didn't feel it. One of the reasons is likely the gauge of the needle is so small, it's less likely that you're gonna have real symptoms with it. So it's given in your deltoid, and common side effects, which are appropriate in about 48 to 72 hours is how long they would last, is the pain at the injection site, swelling, feeling tired, headache, muscle ache, chills. Some people have experienced flu-like symptoms, fever, vomiting. And one other important point, next, is this lymphadenopathy. This is something I experienced, which I initially was a little frightened of because I had lymphadenopathy in my, right in this region for almost 2 to 3 weeks after I received the vaccine. But this has been seen in about 13% of the people that have received these vaccinations. So if you do get lymph nodes that are inflamed at the site, the side of your body where you received this vaccine, that is normal as well. And that should go away at max in about 2 months, but it should go away in several weeks as well. So it's not something to be concerned about. If it lasts longer than 2 months, then of course, talk to your provider, clinical provider. And these symptoms, if you do experience them, that does not mean that you have a virus or you're getting sick. This is how our body responds to different vaccines. It kind of revs up our immune system as that cartoon showed. It gets the antibodies, our body's own military getting ready to fight off a virus, and produces those antibodies that our own body's armor. Next slide, please. So these are a couple of common myths that I'm going to go through and talk to you about. One is these vaccines were rushed and they're unsafe. This is not true. We have now tested these vaccines on over 100,000 patients and have administered more than 90 million doses just in the United States alone. They're effective. They were not rushed through. The sad part is we had so much virus in our country that we were able to do different phases of the study concurrently, because at the end of phase 1, we would start phase 2. That's what allowed us to kind of go through these phases a little bit quicker than other diseases that we're trying to develop vaccines for. Next one is it changes your DNA. As the cartoon showed, it does not change your DNA. These mRNA, they're a little, almost like a recipe that we're giving to your body to make that spike protein. And soon after that spike protein is developed, that doesn't stick around and it can't incorporate into our DNA because it doesn't have the machinery to do that. It can give you COVID-19. That is not true in any sense of the word because there's no live or dead particles of the virus in any of these vaccines in terms of the COVID-19 virus. It contains egg proteins, it does not. So you can get this even if you have had allergic reactions to egg products previously. It causes severe side effects, it does not. Symptoms, people can have mild symptoms, they can even experience fever. And some of the data is showing if you were previously infected with this virus and recovered, you may have a more robust response to these vaccines and get chills, fever. So that should not last more than about 42 to 72 hours. And if it does last longer than that, of course, seek medical attention. It makes women fertile. It does not. I will actually talk about some studies to the contrary to that, where this virus is deadly for pregnant women. Next slide. So there are some contraindications in who should not get these vaccines. And that's if you've had severe reaction to the vaccine, anaphylactic type reaction, where if you've received a similar type of vaccine previously and had difficulty breathing, or your tongue swell up, or you had a severe rash across your body, that's one contraindication to not get this vaccine. Next. or immediate allergic reactions to any portion of the vaccine. One that's included in these vaccines is this polyethylene glycol, which is also found in Miralax. So if you've ever had a anaphylactic type of reaction to Miralax, that may be an indication that, hey, I may have some allergic reactions to this messenger RNA type vaccines. The Johnson & Johnson vaccine would be appropriate to get because it does not contain this polyethyl glycol. Next slide. So that immediate allergic reaction and severity to polysorbitol, which is also a cross-reactivity to that polyethylene glycol. Next. Next. So there have been some reports that have been the early signs, and the number of people that have experienced anaphylactic reaction to these vaccines were reported at 11 and 2.5 per million doses of the Pfizer and the Moderna vaccines, respectively, with no fatalities. I mean, that is literally a drop in the bucket in terms of anaphylactic reactions. Nancy, from her days as an anesthesiologist, could tell you that's probably on a daily basis in some cases that you'd see anaphylactic reactions to different types of medications that were given. But across the country, the number of people that experience anaphylactic reactions to penicillin is markedly higher than what we're seeing in these vaccines. Next slide. There have been some report of thrombocytopenia, which means a low platelet count. Platelets are important in helping us fight off any cuts that we have. So there have been 40 cases reported where those platelet counts do decrease in over 31 million vaccines that have been administered, and possibly one fatality has been seen several weeks after the vaccine. Next slide. And those are being reported and being further looked into. Another important study that was posted just a month ago now, a month and a half ago, and has further looked at this, that people that have received the vaccine after being previously infected show a greater immune response with that first shot. So what the studies looked at, it was a small group, about 41 patients. They saw that after that first shot, they had a more robust response to the vaccine. Their antibodies was 10 to 20 times higher than people that had not had the infection previously. So the data is still, we're going through it to see if it's effective for people to have just one shot. At this point, the recommendations are you should get both shots for the Moderna or Pfizer vaccine, or just that one shot for Johnson & Johnson, but at least 90 days after you recovered from this infection. As time goes on, we'll have more clarity, and it may be down the line, we'll have more data to say one shot of either one of the messenger RNA vaccines are effective. But at this point, we don't have that data to recommend that. Next slide. So the good thing is Dr. Anil touched on this, that this UK variant that's more contagious and possibly more deadly, both the Moderna and Pfizer vaccine seem to be quite effective in giving us protection against this variant. Next. So the vaccines that were vaccine used against that variant that was initially found in South Africa produced a lot lower level of antibodies, that protection that we need for our body, almost 6-fold less, suggesting that there's potential risk of our immunity waning against the South African variant. So that is concerning. Next slide. The other point is that Brazilian variant also has those similar mutations as the South African. So that is also concerning, where these vaccines may not be as effective. Next slide. So this is literally from the CDC website, and I got these numbers from last night in terms of how many cases have been reported across our country. If you look at the top left there, the B117, that's the UK variant, and so far in the United States, we've had about 3,000, more than 3,000 reported cases of those. An important point there is these numbers are coming from random sampling that we're doing throughout our states, and that number prior to a month ago was 10 to 12 random samples per week. It really wasn't a robust number of samples that we're looking at. It was really, really small, and out of that, we have already diagnosed or confirmed more than 3,000 cases in the United States of this more transmissible and possibly more deadly virus. variant. So if you look at Florida, being blue here is a bad thing, because Florida, as we get higher number of confirmed cases, the bluer it gets. So Florida, as of yesterday, had confirmed 642 cases, and the next state with the highest number of confirmed cases was California at 262 cases. So you can see that we're far above the rest of the country in terms of how many confirmed cases we've had for this UK variant. So that is concerning, as we have kind of not mandated a mask mandate, as well as having different events such as, you know, Bike Week, Super Bowl, all these other events that are kind of spreading, kind of the jumping board for this variant to be spread across the country. Next slide. So where are we in terms of vaccination in our country? So far, from December 14th to now, it is pretty amazing that we've administered 90 million doses, reaching almost 18% of the population in the United States. And that's pretty amazing in terms of how many people we've been able to vaccinate. And we're now up to 2.2 million shots a day on average, which is fantastic, which is where we want to be. Next slide. This just gives you an idea of the different states, and that darker green tells you more than 10% of the population in those states have been vaccinated. Next slide. These are a couple of studies that were just published last week. I'm going to review two of them with you. One being body mass index and risk of COVID-related hospitalizations, ICU admissions, as well as needing to use a mechanical ventilation support, as well as death. Next. The other way. You're going backwards. Yeah, keep going. The other one. Yeah. So this looked at 150,000 adults who visited the emergency department or were admitted with COVID-19 from March of last year to December. Next. So what they looked at and found was 28% were overweight with that body mass index, and 51% were obese. Overweight was associated with increased risk of requiring mechanical ventilation, and obesity was associated with a higher risk of hospitalization, ICU admission. But what they saw was when that body mass index was higher than 40, the rate of mechanical ventilation and death was increased markedly. Next. So the author said the higher BMI was associated with more severe illness due to COVID-19. Next. And so what the recommendation was, we should likely be addressing patients that have morbid obesity or BMI greater than 40 more intensively, putting them into the ICU faster, earlier, and just keeping a closer monitoring system with them. And the thought process behind that higher weight having a worse outcome goes with the hypothesis that adipose tissues cause more inflammation, and that inflammation is also further being enhanced with the COVID-19 infection. The other important study that was just published a couple months ago now I want to review with you all was the clinical guidance of hospitalization with women giving birth with or without COVID-19. And this was quite eye-opening as well. Next. So they looked at 400,000 women hospitalized for delivery from April to November of 2020. Next. And they found that about 1.6% were diagnosed with COVID-19. Next. So having COVID-19 versus not having the infection was associated with multiple complications during pregnancy, which include increased C-section rates, preterm labor, needing breathing support, blood clots, heart attack. Next, and the most eye-opening finding was that COVID-19 was associated with markedly higher death rate, 141 versus 5 deaths per 100,000 births. That's the eye-opening finding. So what the authors are saying that pregnant women should have access to these vaccines and also be included in these clinical trials for these vaccines. Now, granted, Pfizer has recently enrolled pregnant women for these vaccines as well. But we don't know the long-term effects of these vaccines, but the reality is these vaccines, there is no live or dead components of the virus. So they essentially should be quite, they should not cause any harm, but the data is really not there yet, since that is now being studied. Next, I think that's it. That is it. Great. Any questions?
We
I
have
know
a
we had
lot of
some.
questions
Okay, let's start.
that have been, a few submitted before the meeting and several since you guys started talking. I'll start with one that we got prior to the meeting. The CDC announced guidelines regarding the COVID-19 virus and how we can behave after vaccination, but they didn't talk about travel. Presumably sooner or later they will, but in the meantime, do you have recommendations for all of the restless people on this call wondering about travel?
Dr. Anil, you want to take this? You want me to take it?
Sure. The recommendations right now are still to try to avoid travel to places with high levels of disease. And one resource that could be helpful on CDC's website, there's a travel section where they actually provide essentially like a risk score of whether it's high risk or low risk for each particular country. And the sentiment is that if it's a low risk place and you choose to travel, obviously nobody can say you're forbidden, right? But if you choose to travel to a lower risk place, just please be mindful of all the places where there can be risk. And that includes in the airport, in waiting areas, in public transportation, in the plane itself, wearing masks, doing things like when you get on your plane, disinfecting the tray in front of you. When you're taking public transportation, making sure you and the driver are wearing masks and that you're trying to keep as much distance from other passengers as you possibly can. And doing all these, and then when you're going to restaurants, really trying to avoid indoor eating as much as you possibly can, choosing places that might have outdoor eating for if you're wanting to enjoy a restaurant or continuing to do takeout like you may be doing at home currently. Those are some of the kind of precautions that you can take. Again, the recommendation still is to avoid travel to higher risk places, which is a decent subsection of the entire world right now. And obviously United States is sort of the trailblazers with that. So
Also within the universe of people who've been vaccinated, trying to figure out how to navigate their new, slightly more flexible lives. If people have all been vaccinated, what would you consider a safe group to be getting together without masks? This particular question had to do with a bridge group. If they come all together and they've all been vaccinated, can they ditch the masks, or is there some number of people at which point you should not?
So the guidelines, go ahead. Yeah.
So I think this goes back to, the individuals getting together, not having all been confirmed to have been vaccinated. If any individual in there isn't vaccinated, and particularly if they're higher risk, then masks would be required.
Sure.
Yeah, and I piggyback on Dr. Anil's input there. Is that traveling portion too? So if you're flying in a plane, if you're sitting in a train with multiple people around you, those are high risk things. So if you, as much as you can, to allow fresh air to come in. So if you're going to visit family or friends, try to do it outside. If you're going to a restaurant, try to sit outside. Those are the really important points, to get that fresh air to come through, because the rate of transmission just diminishes markedly when you have fresh air coming through and getting that.
Another question, again, having to do with being vaccinated, but for people with pre-existing conditions like COPD, are there additional protocols they should be aware of, other than obviously not to continue mingling with people who might still not be vaccinated?
It really comes back to the same tried and true preventive protocols, wearing a mask, social distancing at the forefront. Really the two from the beginning of this pandemic that actually has been data driven, has been shown to reduce the likelihood of any respiratory illness, and specifically for COVID-19, because the possibility of airborne transmission, which means that small microscopic, particles from when you're talking or breathing can be suspended in the air and can stay in the air for sometimes up to 3 to 4 hours, and that can be inhaled by somebody else. So really trying to focus on those preventive actions to be able to protect yourself and protect others. And remember, you wearing a mask really, it's most effective at source control, at being able to keep your secretions and your respiratory virus droplets from being aerosolized to be inhaled by other people. It also confers you some level of protection as well, but the people you surround yourself with, ideally being vaccinated and also wearing masks, is the preferred kind of gathering.
A couple of different questions that have to do with people's concern for other people, often children, therefore younger, and how much they need or might be eligible for the virus, for the vaccines. In one case, we've got a member with a healthy 23-year-old child who's eligible as an essential worker, but her board certified internist advice was he shouldn't get it, which she found peculiar, and I'm happy to see you agree. If that's a quick answer. But in another situation, another son, older, scheduled for surgery in April, can that potentially qualify him as a medical risk since he's going to be in a medical facility at least overnight, or not? Or are we grappling with those kinds of issues yet?
I know in our clinic setting, we have patients that are vulnerable. That's kind of the population that we're looking at this point, trying to get to that population that are older than 60 starting on Monday in Florida, as well as those with underlying medical conditions that could have a bad outcome. So if you're younger, going to a hospital for a surgery really wouldn't qualify you for that unless you have some sort of a underlying disease process that decreases your immune system. Granted that when you're in the hospital, everybody should be wearing a mask, and you should be wearing a mask as well. So that technically wouldn't qualify for it if they're young and otherwise healthy.
But if you're 23 and you're an essential worker, you should be getting the vaccine.
Okay.
For sure, yeah. And I'm talking about the latter case where somebody's going for elective surgery or surgery that's coming up. But if you're an essential worker, get it, please. It doesn't matter what age you are, get the vaccine. If it's available to you, there's a reason why it's available to you, because you're at high risk of contracting this virus. And the other important part is spreading this virus pre or asymptomatically to other vulnerable people. So please get vaccinated if it is available to you.
Well, and in that spirit, what would you say to healthcare workers still hesitant to get the vaccine, if there's anything you haven't already said?
I would say do it to protect your patients, do it to protect your coworkers, do it to, for the greater good of why you are in healthcare to begin with. It really is. I think this collective good of what we are doing as a society seems to have, been lost prior to maybe the last couple of months, and we're starting to hopefully see more discussion and voices that are expressing the importance of that. We're in healthcare to serve our patients and to improve the health of individuals and populations as a whole. And it's a public health priority, plain and simple. This is, you vaccinate to protect yourself, you vaccinate to protect your patients, to all the loved ones around you, all the friends around you, particularly the ones that are higher risk for severe illness. And we've seldom experienced a virus in this country as transmissible as COVID-19 virus has been. This really does take us back to the days of 1917, 1918, H1N1 influenza, the last time we saw something that had this kind of impact. And, the transmissibility, the only thing that comes to mind that is more transmissible than this as a respiratory pathogen is measles, and fortunately, majority of the the country is vaccinated against measles, but we see periodic outbreaks of that. And what has caused those? It's been when the concentrations of people who've been vaccinated against measles has gone down. And so vaccines work, and they're very important.
And Elizabeth, on that point, some of the data coming out of Israel is also showing, because they've done a lot of higher rates of vaccination for their older population, that the vaccines don't only protect you, but it may provide a degree of protection against that asymptomatic transmission. That data is still coming out. So you're not getting vaccinated just for yourself, but also for your loved ones at home that you may infect unknowingly with this virus asymptomatically. So that's an important point.
It's an area that's not completely understood, but it's almost certainly we reduce the risk of transmission by getting vaccinated. We still have in place recommendations to keep wearing masks and socially distancing because we don't know to what extent, and every one of these vaccines will be probably studied in that capacity. And the data he's referring to does, have some very, very compelling findings that asymptomatic transmission is reduced with the vaccine that was studied.
I hate to stop, but we promised people we would let them go watch the president. And there are a handful of additional questions. If you guys are game, I'll send them to you. And if you have quick answers, you can email back. I'll post them on our site when we post the meeting. But I feel like we need to let you go, Nancy.
Yeah, I'm fine hanging around for another 5-10 minutes and answering questions if people are interested in sticking around. Yeah,
Okay.
I'm fine with that.
We're getting lots of also enthusiastic thank yous for all the information that you've given us. I'm trying to get back up to a couple of questions that I can no longer see. How sick will the average person get if they're exposed after having been fully vaccinated?
Typically not sick enough to go into the hospital because there were no hospitalizations or deaths among people that were vaccinated.
This is wonderful. And will the vaccine, should you take a COVID test, will you test positive?
So you would test positive for that antibody test that looks at if you've previously had the virus, but you should not test positive for that PCR test. That's the irritant one they shove up your nose.
Yes.
So that's the one, it will come back positive if you have active infection, but that antibody test where they prick you and get a couple of drops of blood will likely come back positive if you've been vaccinated.
Okay.
And likewise, the rapid antigen test would also only come back positive if you get the infection, not from the vaccine.
And one sort of broad question, given all the variants that will continue to emerge, is there any realistic hope for a vaccine broadly enough targeted to take care of them all?
Yeah, it's the one vaccine to rule them all from
Yes.
Lord of the Rings. Yes. So there are actually working on this type of vaccines, kind of a booster to an extent. The Pfizer and Moderna companies are working on them right now actively against the South African variant as well as the Brazilian variant. So it may be that this virus, we may need a booster shot once a year to give us that protection, that level of protection. But there are active vaccination trials going on right now for that purpose specifically.
And in in the bigger picture, there's some chatter of scientists talking about one day, this is not in the next year, maybe not in the next 5 years, but one day we may have a universal coronavirus vaccine that could be effective against all strains of coronavirus, including the common cold coronavirus. And something like that would be exciting.
That would.
I don't know how feasible that is and what time frame that would ever end up happening on.
Well, and I think the last really key question that I have not gotten to you is a concern about the fact that we are now making progress here in this country, and other highly developed countries are paying for their vaccines. But how much of the world do we need to vaccinate for there to actually be getting on top of this illness?
Good question.
That's a great question, honestly. I mean, it's the elephant in the room, I think, with our vaccine rollout. I mean, we have a flaming pandemic in this country, unparalleled in the world right now, and so we really do need to focus just from a containment on our population to try to be able to get vaccinated. But we know that we're in an interconnected world as well, and that with travel, variants and people who are infected can come from anywhere in the world, and it's the whole reason that I think President Biden has re-entered into a multinational agreement to try to improve access to vaccine to countries that cannot afford it. What timetable these will actually be provided, I'm not sure. I'm not even sure if President Biden knows, but it's important. It's absolutely important.
I mean, it is true when, this virus is all across the world. Until we get the virus controlled in the rest of the world, we're all at risk. So, I mean, the quicker we can get the vaccine available to the rest of the world, especially the developing nations, the better it is for us in the United States as well, to be able to do everything that we want to do. But at the same time, once majority of the population has been vaccinated, that number can be 75 to 85%. But at the same time, once we've gotten that vaccine across the world, we can go back to some sort of normalcy. But I think we're wearing masks for the rest of this year and possibly part of next year. I don't shake hands with anyone anymore. All I do is it's an elbow bump or a hi from a distance. I hug my patients prior to this. It's just been so hard to do distant air hugs, and that's all you can really do at this time. But we've kind of come to a new normal, but hopefully we get back to some normalcy. And the way we do that is with these vaccines.
That's it from me. And thank you both so much.
Thank you. Thank you so much. Really, it was very informative. Very informative. I love how Florida's #1. Woohoo. Way to go. Way to go.
That's the scary
Ron.
part, Nancy. We're like way above everybody else. That's the scary part. That's where all the epidemiologists are concerned that, yeah, we're getting people vaccinated, but this variant is raving across the country and across our state. So
yes, and people, whatever. I
Spike week and the Super Bowl in the last 1.5 to 2 months.
Yeah.
That is frightening.
Yeah. Well, I will go back to the final 2 slides here. Elizabeth, we did have a wrap up here real quick. 2 things to tell you guys before you go watch Joe.
Well, you'll be delighted to know we were planning to give a more detailed legislative update. It's moving too fast. There's too much going on. If you haven't already signed up for one of these 2 action alert bulletins to give you constant updates, do. And if you don't have time to write this down or don't want to scroll back through, all of these are on our website on the Get Involved page. So that's what you need to know. Find the issues that you care about, call them and email them and harass them every day. There's so much going on, but we don't have time for it tonight. And our last slide was going to tell everybody, remind everyone, our speaker in April is going to be Matt Carlucci, who was a good ally on the Lot J and who is likely to be a mayoral candidate, though already far underfunded relative to some others. So it'll an interesting opportunity to meet him, hear about his priorities for the city, and talk to him about ours. Thank you, everybody who came. And thank you most of all to our speakers who really have given us quite an education tonight.
Yes, thank you so much for your time, everybody. Thank you.
Thank you for the invite, you guys.
Thank
you. Be well.
Thank you. Bye-bye.
Bye-bye.